So this is one of the very interesting case that was involved in parts with Dr. Cork, and it's a challenging biliary intervention in an altered upper GI anatomy. For this case, there will be two main points of discussion that I will ask the audience, and then finally we'll also let you guys know what we end up doing. So for the case overview, we have a 71-year-old gentleman over. He underwent pylorus preserving Whipples back in 2023 for the tubulovillous adenoma with high-grade dysplasia. Um, Per documentation in the past, his post-operative course has been complicated by significant weight loss, malabsorption. There was also concern for a short efferent jejunal limb. However, his symptoms improved with pancreatic enzyme replacement and there was weight stabilization. Um, Looking back at the notes, there was a concern that at the time the surgeon might have started doing just the robotic Whipples. And we also had one other patient, and we thought the possibility of the short efferent limb. But at that time, patient decided not to do any endoscopy, so it was never confirmed initially. However, in 2026, there was imaging obtained based on the labs. There was elevation in the liver enzymes mildly, and biliary dilatation was also noted, and there was suspected choledocholitis. So as mentioned, the imaging was done. It showed there was intrahepatic biliary duct dilatation. There was post-surgical Whipple's anatomy. The MRI did indeed show, as the imaging is pointing to, a filling defect, which was proximal to HJ. There was also mild pancreatic dilatation at that time. So ERCP was planned, which happened in April of 2026. There was extremely short front limb, as it was suspected, and actually the scope was able to easily traverse into the colon, as you can see on the imaging. There was very long afferent limb, and HA could not be reached. So this is our first stopping point. I think over here, what are the basic, how should we approach in a patient with the Whipple's anatomy? And in particular, how would we try to obtain biliary access, especially in this case? I will open it to the audience for the discussion.
Was he having pain? I missed that. I saw the thing about the weight loss and all that, but is he having...
There were some non-specific symptoms that has been ongoing, and that's why I think the imaging was done and the labs were obtained. Very non-specific symptoms.
Not really pain. He had been losing weight, but that was after the Whipple. That had sort of stabilized, and he was having intermittent night sweats. So there was a concern for some low-grade cholangitis going on.
Very decided part is my partner. He'll be here tomorrow. Tomorrow, yes.
I don't know. I mean, I'll tell you what we would do. Like, I mean, we do have balloon enteroscopy post Whipple. We probably give that a shot to see if we get to the anastomosis dilated, stone out. You know, we have the short version too, which a lot of the long length ERCP devices can push as well.
I think we would do the same. We try to approach for simple. I don't do it, but we have a small bowel team that will get me there. And I guess I have not done it really, but putting in axios in the small bowel limb near the anastomosis to try to get access. The only part is knowing exactly where to put the axios. So some people put a PTC, inject contrast, dilate the legal bowel so you know where to target. But if you're going to do a PTC, then see what they can do. Maybe they could also deal with the stone too. It's not a case for your first week.
So in slam the earrings, apron length, going towards that is quite long in here. PCF, the scope length is around 106. I'm saying they're working generally speaking. Maybe so that could not make it. If The double balloon periscope, which is used for the purpose of ERCE, is a shorter. That's 155 centimeter long with the working channel of 8.2 millimeter. So that is the one which you can use. The regular periscope, that accessories will not go through that. The only thing which would go through that is CRE balloon, which is long enough. Don't have accessories like balloon and other stuff that would not go through that. So number one option I would try is try a short balloon here. So stone goes through that, balloon goes through that, and we. But the thing to that is this working channel, whenever you're in these ones, you have to evaluate policy.
Oh, we don't.
And CRE,
He's having another phone now?
Yeah.
Okay.
so bigger balloon go through that.
Not good.
That's small. Okay, so
Yeah. We can back on that.
that can.
Sure.
Second option is
That's not his fault.
and not get the end of my hepatomegaly ask me. Okay, put a plug here and put that nasocystic tube into that. And after take the spore bottle and fill that limb with a lot of saline and contrast substance. That would tell you the end of that loop, which is closest to the stem. That's where your human composite medicine. And then that will just find a way to put that next system. For some reason, you're not able to do two other options. One is percutaneous. And what they can do is like they can do a PTC, let the track look short, they have a slice hole, short one which can go through. That would be number three option. As a last resort, you can access transgastric left resistance. With that, both and there get up it's like a response. That for benign disease really, I would have said we have not done that, we have done that. And if that is you is through the left lobe, ideally segment 2, because that gives you a straight shot. And other option is from segment 3. Get the wire across that anastomosis. After that, get us that now the CRE hurricane that will go through that. Dilate a couple of times and try to push that stone down there. But for that, you leave this gap, or you're leaving this connection between the stomach and left lobe of the liver. So it would be better to just at least put a little bit and do that. Let it stay there for 3 weeks and then you can take that. So these are the different options.
Can I ask you a follow-up question? Sometimes even what seems like it should be a rather straightforward parts of this endeavors that you described become rather hard. Like passing a nasocystic tube into the limb. Times, any tricks on that? Because it's either curls in the stomach, you can advance it, all challenges.
But pass that through the
Pass it through the scope.
Yeah, keep the scope there, pass it through it.
Okay.
Keep it there, and what's going to happen is if you have a wire in there, I just did a sheet before yesterday. So what happens with that is, like once you put that in, the distal end will come out of the scope.
Yes.
Have a wire there, but let it and then gently shake the scope and take it out. The tube stays there. You're not going to move with the wire under floor.
Just through the scope.
Yeah.
Through the short double balloon stroke.
Shorter. So it can easily go and you still it's long enough. And even if it goes like when you're coming back and you don't have a space and it goes into the and disappears into the scope, just shake the scope and pull it back into sleep. Because of the space there.
Just throw out two variations. I know Dr. Prasan gave a very nice of all the options. I would just say also that I wouldn't underestimate what radiologists do. So our IR guys now are very good. They do have percutaneous tracheoscopy. They can dilate the tract, stones out. They can do quite a bit actually. So I don't know, at least at our center, we would probably go that route before we think of a land and city.
So, yeah, for us, lands would be number 2.
Okay.
Properties would be number 3. Transplastic would be number 4.
But it might depends on that.
Depends on who
Is
like.
it transplant case, they will never pay it, or definitely.
Or in transplant case, your second option is fair property.
Yeah.
There's no lands, there's no
Right.
translates.
Yeah, but it'll all be your local.
Yeah, that's.
Politics and
yeah,
local.
No, the local love, but that guy's.
Yes. I live in practice, focus in practice for PH and practice. And often you get a storm because of a small structure. And then we dilate the structure up. And then actually I like the fully covered soft. And I put that out of the position. Then instead migrate, it just moves out. What's I thinking I was saying is more dangerous because it's safe. It's safe. The Bible is very soft. And if it migrates, it's fine. And
So that's a bit far of the thing, because we're just keeping a small here, so I'm not trying to put an understanding here.
if you have a structure, if you have a structure.
Yeah, I'd rather dilate it and because the can't be shipped. So how you're going to pay for it? In a benign. So if it's a cancer, then it will be.
It's also brought the other variation to the EU-West intervention, right? And so that was always my area of interest before of research. But we've done cases where we'll do similar to what Dr. Hassan was saying, but instead of just puncture transgastric, but we'll feed a wire all the way down as far as we can down that outer limb, and then go on the reverse side with the monoscope and then to the upper scope. You might not be able to get to that, but get to your wire, you can pull yourself up, or you can think about doing that with your IR colleagues. Wes.
We do a lot with our colleagues, they're happy to provide us with the access, and we do all the cholangioscopy. And now all the major cholangioscopy has compatible devices you can grab with the snare, or do your child grab this.
The spoon is not very big and it's very small, 7 millimeter. I think in this one, I will, based on like what you're comfortable, I think your IR is good, the PTC and then just like
What did you guys do?
All right. So moving along, on the same day, we did the. Oh, can you guys hear me?
Yeah, we can hear you. But
Okay, perfect. So moving along, the same day we did the EUS part. We obviously found the choledocholitis. There was a stone in the hepatic duct. Since the afferent limb was exceedingly long, decision was made to create an EUS guided gastrojejunostomy with 15 millimeter Axios, and then it was dilated to 15 mm. The ERCP was deferred at that time to allow the tract maturation. And in the pictures, you can see the Axios stent deployment, and then the dilatation, and then the final Axios JJ stent placement. So patient came back for repeat ERCP in May of 2026. The ERCP was performed through the mature Axios GJ. Multiple scope was utilized at that time, including the pediatric colonoscope, which had been used previously. At this time, it was successfully reached. We successfully reached the proximal afferent limb. However, the HA could not be identified despite prolonged examination and guide wire probing. But this is our second and last stop. How would,
I'll make some comments here.
Oh, please go ahead. Please.
Before we go on, because yeah, I mean that this is a great presentation, but it should just say ERCP was attempted, because I went in, I can tell by fluoroscopy and just general location that I should be right at the bile duct orifice, but I couldn't find it. I looked and looked and looked. So it was attempted, but it wasn't performed, because I couldn't find an orifice. And then just to add to all that, that was excellent general discussion about this case. But my thought process here was, one is yes, the stone was relatively small, but presumably the reason he has a stone is he probably has an anastomotic stricture. Otherwise, he probably wouldn't form a stone in his bile duct after a Whipple. And so I do a lot of balloon enteroscopy, ERCP. We have the short one, the long one. That was a very good discussion. But I thought it's going to take more than one procedure. If you're going to have a stricture, you have to get all the way there, then struggle to put in multiple plastic stents through an enteroscope. Why not just do an Axios, get easy access for repeat procedures? That was my thought. And then the IR thought was same. I agree with everyone's discussion points, but we have really, really good IR at our hospital too. But, then the patient's stuck with a drain, at least for a few weeks minimum. And if there's a stricture there, potentially longer. So I don't want to subject him to that if I don't have to. And then last point, before we move on, I think there was some discussion about how to put the Axios in. It's actually pretty simple. You don't really need to go fill that limb or get percutaneous biliary access to delineate, because you can generally, after Whipple, follow the sort of the bile duct from the liver and see. You kind of can tell you're looking at the afferent limb, the same way you can follow the pancreatic duct down to the afferent jejunum. So if you can see any of that loop of bowel, I think I was very confident I was looking at afferent limb, and then I just puncture it with a needle, same way you would do an edge with the puncturing the excluded stomach, fill it up, and put the Axios in. So it's actually, I guess, simpler than it sounds like some people think. You don't need to go fill it up some other way, which I think could be useful in the future if someone encounters this case. So those are my points. Thank you.
That last point is well taken. What happens with that is sometimes when you follow it, even though you may be feeling like you're close to that, but where you're going to put that axial. So it's for me, I would consider, I want to know the end of that limb, where it ends really. I want to be as close to that when I'm putting the axial, so I don't have to struggle again to have a long limb and my axios is away from that. So that, and it's not very cumbersome putting up an isocystic. It's just very easy to put that through into different limb and just fill it. But yes, you can do with a needle as this did, and totally acceptable.
So what did you guys do next?
I was going to make
Oh, I'm
quick
sorry.
point. And more for the fellows or any fellows who listen to this, but it's nice sometimes. It can be difficult to find post-surgical pancreatic or biliary anastomosis. Often it's worthwhile to use a translucent cap, a short translucent cap. I'm sure they tried that, but it can help you move the folds out.
Actually, you should not put a scope without that cap.
Yeah.
Yeah. If I have whenever you choose to get scope on the purpose section, we do that all the time, even for regular exam. But this type of yes, you must have a cap. So,
To ask you, there are a number of devices on the market now that provide sort of in a way of rigidizing the over tubes or something with a balloon. Have you guys, what is your experience? Are they useful assessing the situation? Or short double balloon is preferable?
I haven't used any of them.
I use Lumendine. Yes. And just to allow you to pass to get my scope there, and a couple of times, and it did help. So I haven't had this situation where it's super long either. Mine was more just angulation of the bowel. So I knew if I could just get closer, then I could get there with either a therapeutic upload or then I could do everything. I don't know what side of it.
If you're filling the atrium or not, and then you're placing axioms to get
getting, try to get close to the, but are you thinking about the angle that you're placing that?
Yes, that also gives you an advantage with that, if you have built how the room looks like and how your scope is gonna move in. That's other benefit of building that.
And then what are the tricks of finding, because a lot of the times was, bile duct anastomosis is so small when you get there, it's so hard to find. You spend a long time.
Yes.
Any tricks for that?
So with the cap, that's one
Yes.
thing. Second is, it is very easy to retroflex your double loop scope. And actually, I sometimes I do a retroflexion and look at the outputs, and that sometimes can give you a idea. So it's just a meticulous and looking behind the folds, and if needed, just it's like a
To the end of it, you pull back a little PJ somewhere there, almost impossible to see that. And then, a little bit more possible is gonna be the biliary one, so kind of eyeball distance, and then I have to count. But if it's stenosis, that's where you. That is where we're screwed. That's where, I saw the next slide, but I think that's where.
it's also like is look for little clues on the
Yes, what I was hoping you guys tell us, what's the clues?
Yeah,
Come on.
yeah, so that's.
What is suture?
No
suture.
It's not, it's
It's a paper.
yeah, exactly, little upgrade, and the closer becomes a little bit smoother, less lie in that area, it starts to eat that. And that's where sometimes we just out of the wild, which is negative. So these little clues.
It can be tough.
Yeah, it can be so.
So what happened then with you guys?
So this is our last slide, and over here, as you can see, we plan for rendezvous. So AJ was unidentified despite repeat our endoscopic evaluation. EUS was utilized to access the left intrahepatic duct. Transgastric puncture was made with the 19 gauge needle, as shown on the image. And the cholangiogram demonstrated biliary dilatation. There was the hepatic duct stone. There was severe HA stricture, as it was suspected initially, and the guide wire was advanced anteroperantly across the HA into the jejunum. Once that was achieved, then the therapeutic gastroscope was reintroduced, and alongside the guide wire, the bile duct was deeply cannulated with tapered tip cannula, and the second VisiClide wire was introduced, as you can see on the pictures on the right side. Balloon dilation of HA was done as it was stenosed, and the balloon sweeps were performed with the 12 balloon. Sludge was removed. However, despite multiple sweeps, the common hepatic duct stone persisted. And finally, we placed the viable fully covered metal stent across the HA. At this point, the plan is to have repeat liver enzymes in a couple of weeks, in 2 to 3 weeks. He has also been referred for the evaluation of the short efferent jejunal limb. And probably he will come back for repeat ERCP after stricture remodeling for definitive stone clearance. So this is the end of the presentation right now.
So
Yeah, and just of note, the intrahepatic bile ducts were not dilated at all. I think someone in the earlier discussion, that crossed my mind. Could you do a hepatogastrostomy right off the bat? That could theoretically be an option if the ducts had been more dilated, but they weren't. I mean, I really didn't think that would be an option. So even accessing that little duct just for a cholangiogram and wire passage was, you can see it's a small image, but that EUS image, it's a pretty central duct that I could get a needle into. So luckily the wire did go through, because it would have been too small and too far to do a hepatogastrostomy stent. But it did go through, and I had talked to the patient that if this last step didn't work, he would have been admitted and gone to IR for something more definitive, but it worked well.
No, that's a great job on even the cholangiogram. Yeah, we can tell that they are not very dilated, and you have to go to the central part from segment 3. Looks like, and this would not be a good case for gastroscopy.
Right.
We were dilated ducts before, which we, but this would and also accessing that from the central part. You don't want to do a gastroscopy, but you have to go from the periphery. But now this is a great job, and this is sometimes there's these gastric bypass patients. There is this question of they have a stone or they don't have a stone, and that comes all the time. And you are like struggling there. What should I do? Should I even do endoscopy for US? And in the US, sometimes you can see a good amount of the bile duct is dilated, gastric bypass patient. There's a lot of dilated bile duct and dilated because of the vagal nerve injuries and all that. They develop stenosis. In those cases, where there's a question of a stone there or not, I use a 22 gauge FNA needle and do a gas sensing imaging. Yeah, so it's done. Yeah, I do that, get it done with. Tell the patient if you have a stone, we got it wedge. If you don't have a stone, we're done. So it's a very easy 22, but don't use a bigger needle.
And that's really neat. And you haven't had any issues with if it's negative and you just pull the needle out with any leaks or infections?
No, not. We do.
Give antibiotics.
Give antibiotics.
Wow, that's great.
Because it's not even a FND needle. If it's a FNA needle, we do liver biopsies all the time with 19 gauge needle. And
that's true. Yeah.
Stipulating to ourselves in 19.
Exactly. Yeah, and we do for the pressure measurements and so. And we do that often. So it's something great. I think this particular procedure, thankfully, I have not had any problem. So
that's up for us where they say, can't rule out ancillary strictures.
That's like they
just the time, all the time, right?
You're thinking, should I do this patient through double balloon ESPB? Should I do an ad? Should I not do this and that? So I just like talk to them from the very beginning. If I can't see it, and because there is a question, I'm going to do a cholangiogram and get it done. If it drains fine, but there's nothing.
I like that too. Stop the conversation.
Yeah, exactly.
That's a great idea.
Yeah, that's good.
Paul, how difficult was your 19 gauge puncture into a non-dilated sort of duct?
It was very central, and you can see the portal vein was very close to it, and there were that branch that extends out on the cholangiogram. I could see that a little bit with EUS before the cholangiogram, but there were some vessels in the way, and it was very thin. So I went to that central area, and I'd say, it was difficult, but luckily, I think I just hit it on the first shot. So
I'll just say, it can be paid attention. I always look at the fluoro image too before I puncture the lot. So this